Thank you very much, Mr. President. Thank you for the invitation to present shortly, approximately 20 minutes, the organization of the Dutch healthcare system, which is actually quite complicated, but I think I'll manage to give you the highlights of this system. Broadly, this is how it's arranged in the Netherlands. Depending on Dutch hospital care, we have academic hospitals, we have general hospitals, and we have psychiatric hospitals. And then if we look how medical specialists are employed within these hospitals, they can be either working for themselves in private practice, so they make their own companies within or for more hospitals, or doctors are salaried by the hospitals. The thing is that the patient actually won't notice if he is dealing with an employed medical specialist or a specialist in private practice. So it is a kind of a Bismarck system. It is an insured system, which I will comment on later on. But within each hospital, there can be some medical specialists who are salaried, and the other part who are in private practice, but the patient will not notice the difference. Let's see. Now, can you go back to the presentation? Yeah. So, how is it arranged? Because that's complicated within the hospital. If you have a board of directors, a board of a hospital, then you have a complete medical staff. But the medical staff can be in private practice or salaried. So there are different working collaborations between the board. So there can be just one line for the medical staff, so they make one group of salaried and private practice doctors, or they have one. This is always the case. There's what we call a medical specialist company that works within the hospital or for several hospitals, and they do the financial negotiations with the board of directors. And then there can also be a group of salaried doctors. This is the association of salaried doctors within the hospital, and they, from their part, do their negotiations with the board of directors. However, we see now more and more that these two go together. So they make one organization, one association, and together they go to the board to do the financial negotiations. The number of medical specialists are shown here, and I will give my presentation to the organization so they can send it through email for you, so you don't have to make notes. Here you see the total of medical specialists working within hospitals, including mental health care, psychiatric hospitals. More than 12,000 in 2010. And what this also says is that we see some increase in employed doctors and a decrease in private practice. What I already mentioned is that patients won't notice it, so it's only a discussion for the doctors and organization of hospital, healthcare, and the government. So here we see the increase from 32 to 37% of salaried doctors of 2001-2010. If we look at income, and this can be very confronting because if I see the European situation in several countries, this is approximately net income for a senior medical specialist in the Netherlands. And this is differed between employed and private practice. And in history, we saw that this figure was much higher in private practice, but now they are closing more together. Because if you're in private practice, you have to do additional insurance, additional pension funds, etc., etc. And at the end, if you look at net income per year, then you see they're nearing each other. Then the thing about the European Health Consumer Index. Yes, we are for several years #1. This indicator, this consumer index states 48 indicators covering 6 areas. So patient rights and information, accessibility, medical outcomes, ranges and reach of services provided, pharmaceuticals, and prevention. Yes, we're doing very well on this scale. You have a scale of 1,000 max, and we're quite sometime on the top of that. You can download all these reports on the European Health Consumer Index website. And then the first thing is you say, okay, you pay a lot of money. So you spend a lot of money as percentage of GDP in your country, and that's actually not so much the case. So a high percentage of GDP doesn't automatically mean you go high up in this index. For example, United Kingdom stays yellow. Also Italy stays yellow. So, and also the UK spends quite some money on as a percentage GDP, but they arrange it in quite different way. So actually I'm quite convinced that this adapted Bismarck system works very well, and I will comment on it later on. What I would like to focus on is what we're not that good at. So I took here the indicators that are not green. Okay, there are not many from the 48, but there are some yellows and reds. Online booking of appointments, we're not very good at that. Direct access to specialists, we're not encouraging that. So people have to go to the general practitioner before they can come to the general or academic hospital. They have to be advised by a general practitioner, otherwise the insurance companies will not pay. So that's also one thing to limit the increase of costs of your healthcare system. So we're actually quite fond of this red one. Cancer therapy within 21 days, that's a yellow one. We do not very much believe on having terms on cancer therapy. Okay, it shouldn't last months, but 3 or 4 weeks. Sorry, we are not focusing on that. A disease vaccination is okay, but can be better. You can increase this package. And we're not very good at prevention. Not on smoking, not on alcohol, not on physical activity. And that's one of the key points this government and probably future governments and also the medical associations will focus on. That's the more important. So why are we treating only the sick people? Shouldn't we treat the people who are healthy and invest in for staying them healthy? Novel cancer drugs, deployment rate, yes, that's also limited because pharmaceutical companies now charge insane amounts of money for new cancer drugs. So we have to limit that because otherwise the system cannot be afforded anymore. The same for the arthritis drugs. So if you look at the report, these are the comments that the organization who makes this report says. What can Europe learn from the Netherlands? They say it's actually a chaos system where the patients can choose where to seek the care, and it's actually doing better than planned system under the circumstances that you manage it very well. And that is what we're doing actually quite good. Choice and competition, but also here's also a notice on competition, but I think the next one is more important. This is where they say I have to speculate, but I actually have to emphasize on this. Because we have a system in the Netherlands where the bureaucrats, the Minister of Health, is far away from all the things that are organized. I will later on focus on the financial system, but all the insurance premiums that people pay and also their healthcare related premiums they pay within their taxes, they're all dedicated money. So the government cannot touch it. So the Minister of Health cannot say, okay, let's take 10 billion out of this budget and spend it on something else. It's impossible. So every euro that goes to the health insurance system stays in the health insurance system and is regulated by insurers, but also by board of directors of the hospitals and the physicians that talk with the board of directors and the insurers. So the bureaucrats are on a very long distance, and I think that's taking the professional in the lead makes a better system. So what are the main choices that we make? Good medical care for all is guaranteed by the government. So everybody has a mandatory insurance for healthcare. Health insurers may not refuse anyone for basic insurance. That's not possible. So we have a basic insurance package that everyone has to be accepted for. This contribution for basic insurance cannot be linked to the individual client's state of health. And everyone is obliged to take out this basic insurance and to pay the contributions for it. And this basic package includes everything you need for basic, high-quality Western system healthcare. So there's actually not much what excluded from the system. So you can insure for extra. And also, if you're asking from how is this premium related to income, so the people on a very low income, they get an extra tax refund to be able to pay for the premium. But everybody pays the same premium. So this is the system, compulsory basic health insurance. So everyone has to be accepted. Then people can choose to have an additional insurance. You have the freedom of choice. You can have the basic insurance with one insurer and additional package and another insurer. And then you have to think at extra physiotherapy, things like dental care. So the extras that you want to pay for, because some people need every week physiotherapy, for example. Then you have to insure extra. Then we have a long discussion on the care sector, because that was actually, the previous law was the AVBZ, and that was actually an open-ended funding. So that's everything on care. So the elderly care, youth care, mental health care, and every additional tool you need in-house, if you need assistance for cleaning your house, things like that. And everything was paid. There was no budget on it. So that was actually more and more increasing, where hospital healthcare stayed within the 25%. This care, so that's the cure sector. This care sector, in the premiums increased. So they've now changed that. We have now a law that's regulating the long-term health care. So if you have to go to treatment hospitals, so for the senior, for example, not just only if you're a senior, but you need actually to be nursed. And the things like what we call the social support. There's everything you need at home to stay at home and not go to the hospital. So this premium is also income depending, but what I also said, it's allocated, so the government cannot touch it. It's only for healthcare. And there's a large role for the municipal sector, so they have to arrange all this social support in the communities. So roughly, this is the system. Patients has relations with insurer and healthcare provider, and the government only organizes it. So it tries to arrange it that everything works properly. But we actually, these three parts are doing it together, and the government is trying to manage that these premiums don't go up too high and not become a too high percentage of GDP. Healthcare in euros as GDP. This is a graph from 1998 now to 2013, and yes, you see an increase, like in every Western country. Only the steep increase is now, this slope is declining. So the increase is not that much more than we had before. If we look in euros per person, yes, there's a large difference between 1972. Every individual paid 484 euros, and now it's 5,600. So it's a large amount of money. And if you look in what we are spending in which sector, then you see here that approximately 25 billion goes into hospitals, but roughly 18 billion goes to elderly care, disability, more than 9 billion, and more than 5 billion in this care sector. So this care sector is still much larger than this cure sector. Pharmaceuticals, dental care, general practitioner, youth, and paramedic care. Like I said, we'll send you the presentation. If we then compare it to the other countries, then here's the Netherlands. Yes, okay, it's more than 10% of GDP, but also Germany, and also Switzerland, and also France, and also Belgium, and also Canada, etc., etc., etc. And we're still doing better. So, and then the United States, which is completely at a loss because they're nearing this mark of 20%. And this 20% mark is an economic law that says if you go over this 20% mark, you will lose what you call it, the system that you accept that you will pay a higher amount while you're not using that much amount of healthcare. Yes? So that's a dangerous thing. And the United States is not doing very well in healthcare. At the end, we have presented this year this book. We first made the Netherlands version of it, and we now have translated it to English. I used some slides here in the presentations of it. You can, it's 20 euros, and it gives a complete coverage of a very detailed coverage. Even also each law that we use to arrange these kind of things are mentioned here. So it's quite a detailed book. So I used some graphs of it, but I can recommend it highly. So you can order it on this website. So I put in the link in the presentation so you can take it on from there for essentially to order this book. Dutch healthcare system in a nutshell.